Muy bien. Bueno, yo voy a dar la bienvenida en nombre del Cinsan, que es la Corporación de Investigación de Neurología de Santiago, y la Universidad de los Andes, la Facultad de Medicina. Les doy nuevamente la bienvenida. Empezamos con un nuevo webinar del ciclo de webinars en neurología que estamos realizando durante este periodo de pandemia. El webinar de hoy es sobre casos clínicos de neuroinmunología con el doctor Flanagan, la chairman o chairwoman, no sé, la doctora Lorna Galleguillos, de Clínica Alemana y Clínica Dávila. Aprovecho de mencionarle que tenemos un calendario con las fechas y horas de los siguientes webinars. Los invitamos cordialmente para que también puedan estar presentes. Y dejo con ustedes ahora a Lorna, que va a presentar al doctor Flanagan, y luego viene la presentación. Adelante, Lorna.
Muchas gracias. Gracias, Jorge. El webinar del día de hoy, como ustedes saben, corresponde a casos clínicos en neuroinmunología. La neuroinmunología ha sido un campo de gran desarrollo y acelerado desarrollo en los últimos 5 y 10 años, si somos más exactos. Así que tenemos el honor de contar con el doctor Flanagan para contarnos sobre su experiencia y una manera de abordar a nuestros pacientes. Ahora, para que podamos tener una muy buena experiencia de aprendizaje y empaparnos en todo este conocimiento neuroinmunológico, es importante que mantengan sus micrófonos apagados, que todas las preguntas las hagan a través del box de preguntas y respuestas, a las cuales al finalizar la presentación del Dr. Flanagan vamos a contestar idealmente cada una de ellas. ¿Ya? El Dr. Flanagan, como ustedes lo conocen, el año pasado vino al CINS. Él está en Clínica Mayo, en Rochester, y es experto en neuroinmunología. Ahora doy paso al Dr. Flanagan. Please, Dr. Flanagan, we welcome you.
Thank you. Let me share my screen here. Okay. Well, thanks very much for the opportunity to speak to everyone in these kind of tricky times. It's a real pleasure to be able to chat again, and I had a really great time last year in Chile. So thanks to Jorge and all the team, Lorna and all the team, for inviting me. So today I'm going to talk about some clinical cases in neuroimmunology. Some of the cases have some twists that are non-neurologic, but we'll talk about them as we go along. Let me just see. So these are my disclosures. They're not really relevant too much to this talk. So we'll jump right in with a case, and then I suppose I'll take some questions at the end of the talk. So the first case, this was a 30-year-old man. This is a patient that I saw, and he had no prior medical history, but presented with a subacute onset of headache and increased sleepiness. He then, this was happening over the course of a few weeks, and then he developed acute encephalopathy, and he presented to an outside hospital. And when he presented, his initial CT scan showed a large mass here centrally, along with hydrocephalus. So he had obstructive hydrocephalus, and an MRI subsequently revealed this large midline T2 hyperintensity here with associated gadolinium enhancement. So the patient underwent external ventricular drain placement, which resulted in some symptomatic improvement and resolution of the hydrocephalus. He had a CSF study that showed some mild inflammation with an elevated white blood cell count and protein. He had extensive other investigations at the time that were negative. The patient actually underwent a brain biopsy. They weren't sure what the cause of this lesion was, and this brain biopsy revealed some inflammation with macrophages and demyelination, but it was non-specific and there was no particular diagnosis forthcoming. He was given empiric IV steroids and had some improvement with that, and then was given an oral taper and had some fluctuations, but really was not getting better. He subsequently developed some hypothalamic symptoms, so he had hyperphagia, temperature fluctuations, and central diabetes insipidus. His hypersomnolence worsened despite the resolution of his hydrocephalus with the drains, and then he was transferred to Mayo Clinic, where he had an updated MRI. And his updated MRI of the head here, you can see, shows a new area T2 hyperintensity here in the limbic lobe on the left. So this would be consistent with limbic encephalitis. And here you can see some associated gadolinium enhancement. So in addition to the midline lesion, he had this limbic encephalitis. And again, he had no confirmed diagnosis on the outside. He had been tested for a profile of antibodies and initially, but they were negative. But the MA2 antibody was not on the panel that he was initially tested for. And this one in young males is an important one to think about in that situation. When that was found, he also underwent a PET scan of the body that revealed a mediastinal mass, and the biopsy confirmed that to be a germ cell tumor. So his diagnosis was anti-MA2 antibody encephalitis associated with a germ cell tumor, which are known to associate with these. Often they're testicular tumors, as we'll talk about. So he was treated with plasma exchange, IV steroids, then high-dose oral steroids. He had some complications with cyclophosphamide, so this was his treatment regimen, and then he was given stimulant medications because he had the accompanying narcolepsy. He had a moderate improvement, although not a dramatic improvement like we see with some of the antibodies to the cell surface markers. This is an antibody to an intracellular antigen, and the prognosis is often not quite as good as with NMDA receptor antibodies or some of the other cell surface antibodies. When I last saw him, which was a couple of years ago, he continued to have residual memory difficulties, imbalance, and hypersomnolence at his last visit, but certainly was improved when compared to initially and radiologically had improved. So MA2 antibody encephalitis is one you want to think about if you have a young male, particularly because they're often associated with testicular tumors, seminomas, and others. There's kind of three major symptoms that patients can have. The first is brainstem encephalitis. They can also develop a diencephalic syndrome, so they may have narcolepsy, cataplexy. Here's another example of a less dramatic T2 hyperintensity. So this can vary from a large tumefactive lesion to smaller signal abnormalities in the diencephalic region. We also see this with aquaporin 4 antibodies. And then we can also have limbic encephalitis like this patient had. And then some patients can have combinations. So this patient had a diencephalic syndrome followed by limbic encephalitis. And as I said, it associates with testicular tumors and was first discovered by Dr. Dalmau. Just to mention a recent discovery in the last year that we had here at Mayo Clinic in conjunction with UCSF, there's a new antibody to Kelch-like protein 11, which is associated with seminoma, and this was published in the New England Journal of Medicine. They used some sophisticated new methods to determine the antigen, which was quite difficult to find. When we run this on our mouse tissue, we find these little sparkles, and this is a clue to that we see when we run this on our tissue, and then we can confirm with a cell-based assay. These patients present mostly with brainstem syndrome, so they will often have hearing loss, vertigo, and tinnitus. They frequently have ataxia. They can have paraneoplastic cerebellar degeneration and encephalitis. And then this is often associated with a seminoma. And sometimes, you know, you have to look very hard for the seminoma. I've had cases where we had to do a PET scan and go after a small little para-aortic lymph node. So unfortunately, they don't tend to respond that well to immunotherapy. They're also an antibody to an intracellular antigen. So just another one among the expanding list that's getting more and more complicated of our neural autoantibodies, but one to think about particularly in young males with who present with new onset subacute symptoms. Think about perhaps sending this. We do this on a research basis, so if anyone is welcome to reach out to me, and we'd be more than happy to test for this. And MA2 antibodies is the other one to think about in young males. Okay, so move on to another case. So this is a interesting case with a little bit of a twist. This is again a patient that I saw, a 34-year-old male. He had a history of autoimmunity. He was type 1 diabetic, and he developed ketoacidosis in October of 2012. And in the hospital, he was noticed to have quite severe orthostatic hypotension with low blood pressures down to 50/25. And he also complained of vision difficulty transitioning from dark to light. He had early satiety, difficulty emptying his bladder, and orthostasis with frequent syncopal events. So really, he had a constellation of a severe dysautonomia that came on. His past history, he had diabetes mellitus. He was on an insulin pump, and his hemoglobin A1C was not too bad, 7.8. He also had a history of ulcerative colitis, so he had a lot of autoimmune history and had previously had a colectomy. He also had hypothyroidism and had had prior episodes of cerebellitis of uncertain cause, some sort of recurrent inflammatory cerebellitis. He was a non-smoker, didn't drink alcohol, and didn't have any family history of autoimmunity, but a strong personal history of autoimmunity was a clue here to his syndrome. He was on some medications, fludrocortisone, in addition to his insulin, midodrine, to help with some of his orthostatic hypotension. On examination, some of the things that we were able to find, his supine blood pressure was 145/102, and then his blood pressure dropped to 71/42 with a pulse of 72. He had fixed dilated pupils, and he had mild truncal and appendicular ataxia, which was a residua from his prior injury to his prior cerebellitis, and then his sensory testing was normal. So again, lots of features of dysautonomia here, pan-dysautonomia. Here at Rochester, we do a sweat test, and normal sweating, I don't know if they have that available in Chile, but normal sweating comes up purple. So here you can see kind of diffuse decreased sweating in this patient. He also did some autonomic reflex screen where we were able to confirm his orthostatic hypotension, and he had some other changes of adrenergic function also. So in his investigations, initially there was some concern it might be related to diabetes, but when we tested him, he was strongly positive for the ganglionic acetylcholine receptor antibody at 1.45 nanomoles per liter. And this had been normal with his previous evaluation of cerebellitis. So this is a high titer that associates with an autoimmune ganglionopathy. He had low titer GAD65 antibodies, which is pretty common. This is a marker of diabetes. So we felt that this was just related to his prior diabetes. So our diagnosis was autoimmune autonomic ganglionopathy associated with ganglionic acetylcholine receptor antibodies at high titer. I'll just kind of flip over here. We'll just mention that this was first published by Vanda Lennon and Steve Vernino from our group in the New England Journal of Medicine in the year 2000, where they reported this, and they also immunized rabbits, and what they showed was that this induced autoimmune autonomic dysfunction in rabbits. So this is a rabbit here that you can see in panel D, where you see some dilation of the duodenum and dilation of the stomach in a patient who was fed here, and here you can see some dilation of the colon, and then this patient here had some fixed dilated pupils, while not so much here in the control patient. So they were able to show, that's one way of showing that the antibodies are potentially pathogenic when you immunize with animal models. So this shows a kind of proof of concept for this disease. Now, there was a bit of a twist in the tail. So we treated this patient with IVIG, 0.4 grams per kilogram for a 12-week course. And he did have some improvement with that. And his sweat test, I didn't show it here, but his sweating returned and his blood pressure improved somewhat. And he was also given pyridostigmine in addition, and some salt sticks. But it was interesting, after he got his IVIG treatment, he noticed something different in his appearance. So hopefully this is within a couple of days of his first treatment of IVIG. You can see here that here he had kind of what we call salt and pepper hair. So he had dark and white hair, he had a beard here, and then all his dark hair fell out over the course of a few days. Which was very interesting after his IVIG treatment. This is a person with a strong predisposition to autoimmunity. So as I said, all his dark hairs had fallen out, including in his axilla, genital region, and eyebrows over the course of 24 to 48 hours. So he kind of went, there's a term for this, gray in a day or white overnight. So his diagnosis, we diagnosed him with diffuse alopecia areata. So selective dark loss has been reported, and it's possibly due to the white hair lacking follicular melanocytes, which is suspected as the immune target in alopecia areata. So these patients get a selective immune attack on the melanocytes that results in diffuse alopecia areata, and it can come on acutely. And this is another term used. This has been reported before in the literature. Here's another example here. And then this has been termed Marie Antoinette syndrome because her hair allegedly turned white the night before she was due to be put to the guillotine during the French Revolution. A similar thing happened to Thomas More, an English martyr, and there was an increased incidence thought to be due to stress in the setting of World War II. So this has sometimes been termed Marie Antoinette syndrome. There's also been reports, this is a report from The Lancet in 1987, where patients developed alopecia after immunoglobulin infusion. Now, this is an extremely rare complication, and in the setting of the coronavirus, using IVIG is actually a good thing because it's not immunosuppressive in our patients. So I don't want this to dissuade you, but it was just an interesting kind of immunologic phenomenon in this patient. We suspect that the IVIG was related, and we wonder if, you know, IVIG is donor plasma, donor antibodies from the population, and perhaps there was a patient with alopecia areata who donated their plasma, and then the antibodies within that bound to his dark hair and resulted in that. It's also been reported that stress, so maybe the stress of the infusion, or this is a person with a strong predisposition to autoimmunity. So anyway, this was an interesting side complication in this patient, and unfortunately, his dark hair never came back. We've seen him since, and it never returned. So an interesting side note in the patient with a strong predisposition to autoimmunity. Okay, I'll move on to some other cases here. So case 3, this was a 51-year-old female that I had seen who presented with ataxia and vomiting in September of 2017. She had a history of psoriatic arthritis. She also had a cryptogenic stroke in the past in the setting of shingles that was thought to be a VZV vasculopathy. So a little bit of a complicated past medical history, but she presented with subacute vertigo, a vertical diplopia and dysarthria, and then she had intractable nausea and vomiting and some hiccups. Her MRI, I'll show you, revealed some T2 signal within the brainstem and cerebellum, and she was treated with IV steroids and symptomatic medications. These were her medications here. We don't need to go into too much detail here. Her daughter had a history of lupus and positive Sjogren's antibody, and there was some family history of autoimmunity here. She's a lifelong non-smoker. And her neurologic examination, she had truncal ataxia, direction-changing nystagmus, she had left-sided hearing loss, and cachexia, and was globally weak. I met her in the outpatient setting. She was actually quite sick, and we had to admit her to the hospital. She wasn't able to walk, and she had lost a lot of weight from all the intractable nausea and vomiting. This was her MRI here that you can see this T2 hyperintensity within the dentate region here, which was accompanied by gadolinium enhancement. And then she also had a T2 hyperintensity here within the region of the dorsal medulla, the area postrema region, which is the vomiting center of the brain. She had a positive ANA, SSA, and borderline phospholipid antibodies, and her CSF showed some positive oligoclonal bands. But the most important test for her was the CSF and serum aquaporin 4 were positive, and this is known to associate with intractable nausea and vomiting. So we diagnosed her with aquaporin 4 positive NMO spectrum disorder. These patients can have brainstem syndromes. They also have, as per the terminology, they have transverse myelitis and optic neuritis, and they have a particular predisposition for area postrema syndrome, which can sometimes present with nausea and vomiting to a gastroenterologist before they see a neurologist. Due to her ongoing severe symptoms, she was seen, as I said, at Mayo Clinic, and we repeated her IV steroids, and we treated her with plasma exchange, which generally we use frequently in aquaporin 4 positive NMO. It works very well. So she received 7 treatments with a dramatic improvement, and then she was given transitional oral steroids and placed on rituximab 1 gram intravenously for 2 doses, separated by 2 weeks, and she was maintained on monthly treatment. On 6 monthly treatment. Interestingly, her symptoms of the area postrema resolved, and I actually received a call because her local neurologist had done a repeat MRI later that revealed an asymptomatic new lesion. And I'll just show here what the MRI showed. So here you can see this T2 hyperintensity within the right medulla. It's difficult to project here, but the medulla was the anterior medulla here was also enlarged. And you can see the T2 hyperintensity here within the medulla on the sagittal images also. But again, she was asymptomatic with this, did not have symptoms of a new relapse. But her local doctor added mycophenolate to her rituximab as they felt it was likely breakthrough disease. But when we evaluated it, we were concerned that this, she returned to see us, that this represented actually hypertrophic olivary degeneration. Because the dentate nucleus is part of the pathway in Guillain-Mollaret's triangle from the dentate to the red nucleus along the central tegmental tract to the inferior olivary nucleus. And if you knock out the contralateral dentate nucleus, then you will often get contralateral inferior olivary enlargement and hypertrophic olivary degeneration. This is something we see commonly with stroke, and I've seen some patients who have developed hypertrophic olivary degeneration secondary to a dentate stroke, and then sometimes the neurologists think that there is another stroke within the medulla when actually it's just a secondary damage. This has been reported, as people may be aware, with hypertrophic olivary degeneration. We see T2 hyperintensity within the inferior olivary nucleus. That tends to develop within 1 month, and then by 6 months, you'll see olivary hypertrophy, and it persists for 3 to 4 years. And the timeline was pretty good for it in this case. On examination, when she came, she didn't actually have any palatal myoclonus. But we felt it was hypertrophic olivary degeneration secondary to NMO. We don't actually, it's interesting with MS, we don't see hypertrophic olivary degeneration very often, yet we often see lesions within the medial cerebellum. And I think that just talks of the destructive nature of aquaporin 4 positive NMO spectrum disorder, where we get complement and mediated damage and potentially a lot of damage, similar to stroke. So it seems to be in stroke and more destructive processes that we see this, in addition to degenerative disorders. So in this lady, you know, we didn't want her to be too immunosuppressed, so we recommended she stop the mycophenolate and just continue on the rituximab monotherapy as maintenance treatment for her. So something to look out for hypertrophic olivary degeneration. So the teaching points from this case, I think, are that remember, intractable nausea and vomiting is one of the 3 cardinal manifestations of aquaporin 4 NMO spectrum disorder, in addition to optic neuritis and transverse myelitis. So really think about that. Have a low threshold for using plasma exchange in patients with aquaporin 4 positive NMO spectrum disorder. And then remember, hypertrophic olivary degeneration may mimic a relapse of the original insult, usually occurs within 6 months after the initial insult, and palatal myoclonus is a useful clue if it's present. Okay, so we'll keep going. I think we have a little bit more time here, yeah. The next case, case 4. So this was a 70-year-old female. She was an ex-smoker. This is, again, someone I saw in our neurology clinic here at Mayo. She was cognitively normal previously, so this was a pretty healthy lady, driving her car, managing her own finances, very high functioning. And then she developed a subacute onset of a rapid cognitive decline. And over the course of 6 weeks, she was amnestic for a vacation that she'd been on. She was repeating questions. She was misplacing items. She was getting lost in familiar places. And this was very atypical for her and came on quite rapidly. And she underwent an MRI of her head that really didn't reveal any definitive major abnormality. And this is the post-contrast images here. She didn't have severe hippocampal atrophy, but there was nothing dramatic found. This was reported as normal at our institution. On the outside, she was diagnosed with Alzheimer's disease and treated with donepezil given her age, but this didn't really help. And she sought an additional opinion. We did a CSF study, or she had a CSF study. I'm not sure if that was at our center or prior to coming, but it revealed a normal white blood cell count, protein, and negative oligoclonal bands. Her syphilis and HIV serology were negative. So this is a patient, again, who presents with a subacute, rapidly progressive dementia, who's got a normal MRI and a normal CSF study. So there aren't many clues towards an autoimmune etiology here. But she did have positive Tpo antibodies detected on the outside. So they did diagnose her with Hashimoto's encephalitis when she was seen by a second neurologist after being diagnosed with Alzheimer's disease. And she did have some improvement with high-dose steroids. However, we did additional testing. So a CSF and serum neural autoantibody panel was sent, because we know, I'll talk a little bit later about Hashimoto's encephalitis, and Tpo antibodies are very common in the general population. So you need to be careful before stopping at that diagnosis. And this is what her tissue immunofluorescence looked like. So when we look here under the microscope, we usually see, if a patient has no antibodies, this is the mouse brain. We usually see it dark, not light up, but what you'll see here is the cortex, the basal ganglia, and the hippocampus lighting up very brightly here with the patient's serum and CSF in this pattern that was highly suspicious for AMPA receptor antibodies. And we have a cell-based assay that we were able to confirm that she was positive for AMPA receptor antibodies in serum and CSF. She had a remote history of smoking. So we have performed a PET scan, and here what you see is this avid hypermetabolic mass here in the right lung, and this was biopsied and found to be small cell lung cancer, which is the most common cancer that we see with paraneoplastic disorders. So she had a paraneoplastic autoimmune dementia, and it's just important to remember that you know, these disorders can happen to 70-year-olds, and if you have something unusual about your dementia, rapid progression, subacute onset, it's really important to think about neural antibody testing, because in this situation, it helped us find the cancer and help predict how she would do. She underwent oncologic treatment with chemotherapy and radiation, and she also underwent additional immunotherapy with us with methylprednisolone, and actually her symptoms resolved pretty much close to normal with just steroids. Sometimes in these cases, we also have a low threshold to use plasma exchange if we need to, and some of these cases can be very severe comatose, so we generally treat them quite aggressively, but her case was more mild and just required IV steroids, but did respond very well. And this antibody is an antibody in contrast to the MA2 antibodies and the Kelch-like protein 11. This is an antibody to a cell surface marker, so tends to respond better to immunotherapy. Encephalitis and AMPA receptor antibodies, this again was discovered by Dr. Joseph Dalmau, who's discovered many of these antibodies and really been a superstar in terms of discovering many of these antibodies that have really helped us in clinical practice. This antibody can be associated with limbic encephalitis, and lung cancers are the most common, like our patient had small cell lung cancer, and again has the potential for good responses to treatment. And I will tell you, we've had patients who came to our ICU in a coma, found to have AMPA receptor antibodies, had cancer, and were so unwell and so sick that they were sent to palliative care. And we had one patient who returned to the clinic after palliative care, having been given a lot of immunosuppression, and eventually they did improve and got back close to normal. So there can be really a dramatic response, like in our NMDA receptor antibody patients. It's important not to give up on these patients who have antibodies to cell surface antigens. Another article from the Dalmau group and Dr. Grouse here showed that there are these cases of CNS syndromes where they have a normal MRI and a normal CSF, particularly in older people. We see this sometimes with LGI1 antibodies. So in these situations, the antibodies are really, really helpful because they confirm the diagnosis. And usually the clinical syndrome will be a clue. So these are not patients who generally present with a slowly progressive dementia over the course of many years. These usually come on subacutely, but it's really important to test for the antibodies in these cases because that can help you find the cancer and guide the treatment. Just to mention, the Tpo antibody frequency is very high in the general population, 20 to 30% in people who are elderly. So you want to be very careful when you assign the TPO antibodies to the diagnosis. So in this situation, it still was an autoimmune encephalitis, but the AMP receptor antibodies were clearly the cause, and the TPO antibodies were probably just a marker of their general predisposition to autoimmunity. So we see a lot of patients referred to Mayo Clinic who have other diseases. They might have Parkinson's, PSP, and they have TPO antibodies, and they're told they have an autoimmune encephalitis, or they might have a functional neurologic disorder, fibromyalgia, medication-induced or toxic metabolic encephalopathy. So TPO antibodies are not really a good marker, and I would always make sure that if you diagnose Hashimoto's encephalitis, it's a clear diagnosis of exclusion, and you've tested all the other antibodies and you've tested for everything else. So the teaching points in this case: a non-inflammatory MRI and CSF does not exclude an autoimmune or paraneoplastic encephalitis. AMPA receptor antibodies should be treated aggressively, as a good response to immunotherapy is possible. And TPO antibodies are non-specific and not a useful marker of autoimmune encephalitis. Okay, keep going. A few more cases. Okay. These are complicated cases, but these are the ones we encounter. So I think there's good teaching points with each one. So this was a 34-year-old man, and he presented with 1 week of headache, fevers, and then a generalized seizure with some fluctuating encephalopathy. And his examination revealed a subtle right hemiparesis. He developed a right focal motor seizure during his hospitalization. So presented with, again, a right hemiparesis and fluctuating encephalopathy and a right-sided focal motor seizure. And here you can see in his MRI, you can see this, it's kind of difficult to appreciate, but you can see that the cortex is kind of swollen on this side when compared to the other side. And there is some associated leptomeningeal enhancement and even some curvilinear parenchymal enhancement here. And you can see the sulci are full here. So the cortex is quite enlarged when compared to the other side. And this patient had a CSF that showed 387 white blood cells, 4 red blood cells, normal glucose and normal protein. And his oligoclonal bands were negative, and investigations for other causes was negative. So this is another case where an antibody helped figure out the syndrome. And another teaching point is that if you find the antibody, you may not need to do a brain biopsy in some of these patients. We had our first patient who had a diencephalic syndrome, who had MAT2 antibodies that could have prevented biopsy. And again, this patient, if they had figured out the diagnosis, it may not have been necessary. The brain biopsy in this case revealed inflammatory infiltrates and some demyelination. The patient had high-dose oral steroids, and also there was a suspicion that this might be tuberculosis. The patient had some risk factors for that, so the patient was started on TB medications, but eventually they were removed when the diagnosis was confirmed. So the patient was seen by one of our autoimmune neurologists. This was seen actually in Jacksonville, and they recognized this hemiencephalitis syndrome. The patient was tested for Mog antibodies, and the titer came back very high. So this was a unilateral meningitis/meningoencephalitis associated with Mog antibodies. So as you're aware, and for those who were at the talk last year I did in Chile, we talked a little bit about Mog antibodies, which are really part of the new frontier in demyelinating syndromes after aquaporin 4 antibodies. We test this using a cell-based assay, and this just shows you an example of what a positive test result looks like. We transfect the Mog receptor onto HEC293 cells, and then when we add the antibody and we add an immunofluorescent tag, we can see immunofluorescent binding here, while in a negative case we don't see any additional binding above the normal. Mog antibodies are most commonly associated with optic neuritis, and a good proportion, probably about 50% of cases, happen in children. They're also associated with acute disseminated encephalomyelitis. They can have a neuromyelitis optica spectrum disorder syndrome, where they have optic neuritis and transverse myelitis, or they may have a single monophasic transverse myelitis, often involving the conus. But there are other presentations, and the Japanese group here, Nakashima and Agawa, reported this really nice paper in Neurology, the N2 journal, Neurology and Neuroinflammation, where they reported these cases that had swelling and unilateral encephalitis, often associated with seizures or hemiparesis. This was initially recognized, and then our fellow here at Mayo Clinic, Adrian Budrum, who's now returned to London, Ontario, he put together this acronym called FLAMES, so which stands for unilateral cortical flare, hyperintense lesions in anti-Mog associated encephalitis with seizures. And here you can see some examples again of this cortical swelling, sometimes with leptomeningeal enhancement. Patients will often have fever, they'll have seizures, they'll have headache, and they may have other cortical findings, seizures, aphasia, those kind of findings. And the MRI reveals cortical flare hyperintensity and swelling, and sometimes some leptomeningeal enhancement. So this is kind of a new phenotype we're recognizing with the Mog antibody disease. It's important to recognize so that these patients don't undergo a biopsy, and it tends to respond well, like most Mog cases, to steroid treatment. Again, this was a recent case published in Pediatric Neurology Journal. This patient presented with an acute hemiparesis as a stroke mimic, and again, you can see this unilateral enhancement and flare hyperintensity within the cortex. Okay, might have time for one more case, so I'll present one last case, and then we'll finish it up and open it up for questions. So this last case, this is a 41-year-old man who presented with numbness in both upper extremities, and then developed urinary retention, gait imbalance, and numbness in his legs. And this kind of progressed over many months. His mother had a history of lupus and myelitis, so some family history of autoimmunity. And he had an abnormal MRI and CSF and had been treated with a single course of IV steroids, and then was referred to our facility without additional treatment. His examination revealed some sensory loss in the upper extremities to pinprick, but he didn't have severe abnormalities on examination. But what you'll see here is that he had a longitudinally extensive T2 hyperintense lesion, and he had this dorsal subpeel enhancement with some central canal enhancement here that seems to form this kind of three-pronged or trident-like appearance here. We'll come back to. He had a white cell count of 18 in the CSF. He was actually tested for the aquaporin 4 ELISA, but he had a more of a progressive myelopathy. His myelopathy progressed over many months, and he wasn't that severely affected. Most patients with aquaporin 4, if they have this aggressive of a lesion, they'll usually be paraplegic or more severely affected. But he had this aquaporin 4 ELISA tested that was borderline elevated. I'm not sure if in Chile you guys test with ELISA or cell-based assay, so we'll come back to some discussions about that. So on the outside, he had been diagnosed with aquaporin 4 positive NMO spectrum disorder, and he had received rituximab and the single course of IV steroids. But when we evaluated him, we recognized this pattern looked like we have seen with sarcoidosis. So we did a CT chest, which showed some borderline enlarged lymph nodes, and then a PET scan of the body showed these avid lymph nodes, and a biopsy revealed non-caseating granulomas. And we tested his aquaporin 4 IgG by cell-based assay, and actually it turns out his cell-based assay had been tested initially, and that was negative, but the ELISA was positive. So his diagnosis was actually spinal cord sarcoidosis. And he was treated with high-dose oral corticosteroids with a slow taper, which is the typical treatment for sarcoid, rather than acute attack treatment like we would have with aquaporin 4. Just to mention, we have previously shown that this dorsal subpeel enhancement is very characteristic of spinal cord sarcoidosis and tends to distinguish it from aquaporin 4 positive NMO spectrum disorder. Here you can see this longitudinal extensive lesion, again, this dorsal subpeel enhancement. Another example here. Here's another example here. Sometimes you can see the hilar adenopathy on the axial images, and again, some dorsal subpeel enhancement, this characteristic pattern. So if you see this, you really want to think about sarcoidosis. Just to mention subpeel enhancement. So some of these patients can have peel enhancement of the leptomeninges in addition to subpeel enhancement. This is an example of peel enhancement here, where you'll see just enhancement of the leptomeninges. But actually with sarcoid, a lot of sarcoid cases, there's a lot of enhancement extending into the parenchyma in the subpeel region. And it may represent breakdown of the blood-brain barrier at the leptomeningeal vessels. And it may, this finding will help guide your initial investigations at PET-CT over testing aquaporin-4 antibodies. And just to mention about the Trident pattern, so here you can see T2 hyperintensity within the cord, and then this patient has this dorsal subpeel enhancement. In addition, has some central canal enhancement that forms a Trident pattern. Again, this was something we published in Neurology, and here you can see this three-pronged pattern here that formed a trident. So if you see this trident pattern, it's very suggestive of spinal cord sarcoidosis. And the aquaporin-4 assay has improved over time. So when this was first discovered in 2004, this is an example. Each row here represents a neuromyelitis optica case. And what we found was initially when we used our immunofluorescence, when Dr. Lennon discovered the aquaporin-4 antibody, we picked up about 50% of what we now consider NMO. And then we went to the ELISA and we would pick up more. And then when we went to the cell-based assay, we picked up even more. But there is a high rate of false positives with the aquaporin-4 ELISA. So what we found is that the ELISA assay, there's a 5 times increased risk of false positives. So you need to be very careful. And this sometimes results in MS patients being misdiagnosed as neuromyelitis optica, and there's differences in treatment that are important. And the diagnostic criteria paper particularly mentions the importance of cell-based assays. So really, if you're going to test your aquaporin-4, you need to look for a cell-based assay. That might be a FACS assay, flow cytometry, or a dead cell cell-based assay, but really the cell-based assays are what you need to do, because if you do the ELISA, you may get a false positive and it may lead to incorrect treatment. And sometimes the MRI, I'm a fan of MRIs of the spinal cord, and sometimes the MRI can be quite useful, the pattern in pointing you in the right direction. So as I said, consider spinal cord sarcoidosis among the differential diagnosis of longitudinally extensive transverse myelitis, particularly if there's dorsal subpeel enhancement or a trident pattern. And the PET scan is the most sensitive to detect sarcoid. So if you're suspicious for sarcoid and your CT chest is equivocal, it's worth doing a PET scan if you can get it covered by insurance, because it can sometimes pick up things. So you'll see that's a common theme in our paraneoplastic world and in this world, that the PET scans are actually quite useful to pick up some of these smaller tumors. And beware of low positive aquaporin-4 ELISA results, as there's an increased risk of false positives. So I think I'm going to skip case 7, and I think we can move. I'll just conclude by mentioning that yeah.
We can listen to case number 7.
Are you sure we have time?
We are eager to hear it.
Okay, great. Okay, we'll do one last one, and then we'll finish up. Okay. Hopefully we haven't been going through them too fast, but these are interesting cases. This is my day-to-day job, so I really enjoy it. So this was a 29-year-old female, a Caucasian, who presented with the subacute onset of headaches, photophobia, so some meningeal symptoms, in addition to tremor and numbness in the arms and legs. On examination, the patient had a tremor, had hyperreflexia, and had optic disc edema. And the patient's clinical syndrome was felt to represent a meningoencephalomyelitis. And this is an example of the optic disc edema that was seen bilaterally in this patient. The MRI was very interesting in this patient. You can see this radial enhancement here within the brain and also in the cerebellum. And then you can see this scattered gadolinium enhancement and this hazy T2 hyperintensity within the cord, which is pretty typical of this diagnosis. The patient had white blood cell elevated lymphocytic pleocytosis with positive oligoclonal bands. A PET scan of the body was negative for sarcoidosis or other things, and MRAs were negative for any vasculitis. We can sometimes see this radial enhancement pattern with vasculitis or with sarcoid, and the brain biopsy showed non-specific inflammation. And when we tested this CSF, it was actually strongly positive for this antibody that we later found out was an antibody that bound to GFAP. It showed this characteristic astrocytic staining here. that we can see down below. And at the time, these antibodies weren't yet discovered. So this brings up a point that if you have a patient with a very unusual syndrome that you think might be autoimmune, you know, when we run the sample on mouse tissue, the serum or CSF, sometimes we'll see a lot of staining, and we might know what it is yet because we mightn't have figured it out. So if you sent a sample for NMDA receptor antibodies 20 years ago, we would have seen a lot of staining, and we might be able to clue people in, and it's a way we try and discover our antibodies. So when this was first recognized, we recognized it looked like an autoimmune process, and we were able to eventually discover that the antibody was to GFAP, the alpha isoform being the most common. This was published by Dr. Lennon, Dr. McKeown, and Dr. Axmith, who I think talked to somebody yesterday, was quite involved in initially recognizing this syndrome. He sees a lot of meningitis cases, and he recognized this syndrome and clued the lab in to look for the antibody. Patients can have tremor, optic disc edema, and the CSF is the most sensitive and specific way to test for this. So we have seen some serum false positives where the serum is positive and the CSF is negative. So CSF is the best way. Some of these patients will have NMDA and aquaporin 4 antibodies, and teratoma is the most common coexisting tumor. So sometimes we'll see teratoma, they might have aquaporin 4 NMDA, and they may have an overlap syndrome, or sometimes they'll have one syndrome that's dominant, and they tend to be very steroid responsive. And here's this another example of this radial enhancement that we see, and sometimes on the spinal cord we'll see this central canal enhancement. Here's another example of this radial enhancement. So when you see this MRI, you want to think about testing GFAP antibodies in the CSF. They tend to respond pretty well to steroids, and we often use steroid-sparing agents like mycophenolate or azathioprine in that situation. So CSF GFAP IgG is a novel biomarker of meningoencephalomyelitis. And this perivascular radial enhancement's a clue. As I said, we can also see that with vasculitis, with intravascular lymphoma sometimes. We can also see it with sarcoidosis. And we may see a faint longitudinal extensive transverse myelitis with these cases. Okay, so we were able to get through all the cases. This is a good success. So antibody biomarkers, I think you'll get from this talk that they're quite useful in neurologic diagnosis. And it's good to be on the lookout for autoimmune central nervous system cases, as if you find an antibody, it may help lead you to find the underlying tumor and guide your treatment. So beware of antibodies, non-specific antibodies, positive ANA, Tpo antibodies. The neural antibodies are really much more specific and the way to go if you're concerned about an autoimmune condition. So after that blockbuster of cases, I think I'll stop there, and I'll thank everyone for listening and open it up to any questions people might have. And if, I don't know if, Lorna, if you want to explain to them how to do the questions.
Las preguntas, por favor, por el chat de preguntas y respuestas, cosa de poder leérselas al Dr. Flanagan. Y no olviden que cuando terminemos la sesión, contestar la pequeña encuesta sobre la webinar. Well, Dr. Flanagan, the first question is about what do you think about asking anti-thyroid antibodies when you have a suspicion of a rapidly progressive dementia or other scenarios where you think it's autoimmune? Would you think that's important to keep asking them?
I don't. I suppose what I would say is I don't think it's vital. I just think you need to be very careful because you're going to get a 30% hit rate. A lot of these rapidly progressive dementias are in older people. So my sense is if you're going to do that, it's okay, but you need to know how to interpret, and you need to make sure you've looked for everything else. So if everything else looks like CJD and the patient has TPO antibodies, it's probably still CJD. You know, so you want to use your clinical judgment there. While if you have we don't tend to see false positives for NMDA receptor antibodies or AMPA receptor antibodies or ANA1 or other things. So if you see those really specific antibodies, then that's going to guide you more. So don't stop at the TPO antibodies. If you want to test it, it just says that the patient has somewhat of a predisposition to autoimmunity. They've looked before and found that TPO antibodies don't bind to brain tissue, so they don't seem to be pathogenic. So their utility is limited, I would say.
Okay, thank you. Another question about anti-Mog. What is your experience with anti-Mog encephalitis in adults?
Yeah, I've seen cases, and I presented one, I think, when I was there before, where they can be quite severe. So they may have an ADEM-like presentation. They may be comatose. We have seen patients with hypothalamic or thalamic lesions where they're quite somnolent and have issues there. We see patients with brainstem involvement too, so we can see ataxia, we can see double vision, a wide range of symptoms. So Mog spans the spectrum, and then we have this hemiencephalitis phenotype. So we tend to treat them aggressively with steroids and plasma exchange, and then some patients with Mog are monophasic. So in those patients, we usually give them a chance to relapse because 30 to 50% may be monophasic. So particularly with the coronavirus pandemic, we don't want to be immunosuppressing all these patients unnecessarily. So we generally will sometimes do an oral steroid taper and then wait to see if they relapse. But it depends on certain cases. If they go blind in one eye from an optic neuritis and they've only one eye protected, then you may be more likely to use an immunosuppressant. Yeah.
What do you do after 6 months? You do like this slope tapering to see if they're going to relapse, or you prefer to go into steroid sparing agents, or prefer to go directly into rituximab, or you keep following them like a curve of anti-Mog titers?
Well, we base the decisions mostly on the clinical, and it depends on the severity of the first episode. So a lot of patients will have a monophasic optic neuritis, and then we'll wean them off the steroids maybe within a couple of months, and then we'll wait and see and follow. And because usually they tend to respond well to treatment, and they don't tend to develop as much kind of long-term disability from each attack. So, you do have time to treat them acutely. And then if they declare themselves as relapsing, then we will add in, and of the maintenance immunosuppressants, we recently showed that IVIG seemed to be quite effective, actually. Of all the treatments, that seemed to be the most effective. And in children, in discussing people in Europe where they treat a lot of children, they found IVIG quite effective. So IVIG can be used as a maintenance treatment, and that would be probably my first line, particularly in the coronavirus pandemic. Rituximab's been hit and miss. It's much better in aquaporin 4 antibodies, not so good. Mycophenolate azathioprine can be considered, kind of thing.
Great. So there's another question. If you're very suspicious that your cause is autoimmune, but your first panel in the Mayo Clinic is negative, when would you repeat it? Or is it worth it to repeat it?
Yeah. Well, it depends. So if there was anything interfering with it, for example, if you sent the antibody after plasma exchange, you might want to consider resending it. If you sent a serum only panel, for example, some antibodies are better detected in serum. So if you sent a serum only, you may miss NMDA, which is better detected in the CSF. On the contrary, if you sent CSF for LGI1, LGI1 is actually better detected in the serum. So I would check and make sure that you did the right sample. And if you did all that, it's pretty rare that we find that they're detected again. If you're highly suspicious, there are always chances of, in our lab, we do 200,000 tests per year. It's always a chance that a slight error or something spilled, or, so it would be more for those reasons that you would repeat rather than patients developing the antibody later, if you know what I mean.
So there's a question in English, so we just read it. So this is Lucila. I would like to ask if you have any experience in the management of combined central and peripheral demyelination. I have a patient with a CDP suspicion who did not respond to steroids and IVIG.
Yeah, we have seen some, neurofascin antibodies can be tested for. They're probably the most common antibody that you can look for in those situations. We've used rituximab with good success. I have not seen many of those cases, but we have seen success with rituximab.
Great. And Dr. Navarrete asked if you always test aquaporin 4 antibodies in plasma and in serum at the same time.
Oh, they might mean in serum and CSF. Serum is better, so we generally do serum. We've not really seen many cases where CSF alone is better. There have been a few, maybe 1 or 2 cases ever that we've maybe seen CSF better. So in general, serum is better for aquaporin 4. Similarly for Mog, serum is better, although occasionally there was a recent report in JAMA Neurology where some CSF it was positive and serum was negative.
Okay, Dr. René about do you think schizophrenia or mild bipolar disease can be a manifestation of encephalitis?
Some patients will present with psychosis and may have some manic symptoms, NMDA, and particularly in young females. So it's something you might want to think about if you have a young female, you know, or be on the lookout. And we try to educate our psychiatrists to be on the lookout, particularly with young females.
She wrote a question about from geriatrics. In your experience, what are the most prevalent autoimmune encephalopathies in the elderly? Do you think there is an undergoing diagnosis in this population? Underdiagnosed in this population?
In the elderly for autoimmune encephalitis, LGI1 antibodies is probably one of the most common we recognize. They often have facial-brachial dystonic seizures. I didn't show an example today, but they get these dystonic type movements. So that is one certainly to think about more in the elderly, while NMDA is more a young person's disease. Yeah.
Okay, and here we have a last question in the chat. It says, Ignacio Albornoz, in the case of Hashimoto encephalitis, Tpo is detected. Well, where it went. Somebody just typed another question and delete the other one. Okay, here it is. In the case of Hashimoto encephalitis, anti-TPO is detected in serum or CSF?
It's tested in serum. TPO antibodies are in serum. Yeah.
Carolina Pelayo, about MA2 antibodies clinical case. Did you prescribe 1 gram of methylprednisolone weekly for 12 weeks instead of 1 gram per day for 5 days, and then maybe prednisone tapering?
Well, I think in this patient we did 1 gram IV of methylprednisolone for 5 days, and then we did high-dose oral steroids. Sometimes we found when you use prolonged high-dose oral steroids, we get more side effects, but we sometimes get more efficacy.
Okay. What would be your plan with a GFAP patient that does not respond to steroids?
With the GFAP patient?
And your image is very characteristic of for a GFAP.
What would be the can you say that again? Sorry, what would be the recommendation for treatment?
Yeah. What would be your approach?
So we usually treat with high-dose IV steroids for 5 days, and then we'll often give high-dose oral steroids and treat it a little bit like sarcoidosis and use a steroid-sparing immunosuppressant and see how they do. They tend to respond pretty well to steroids and steroid-sparing immunosuppressants. So it's more oral steroids than IV.
Any other question, Jorge? Do you have any question we can ask Dr. Flanagan? Because the chat already did them all. Can't listen to you, Jorge. Your mic.
So Professor Flanagan, if you are testing for encephalitis, you test it in serum or CSF or both?
I would do both if you have a patient who's encephalitis. I think doing both is going to cover you. It's hard to remember which antibodies are better and which. This gets so complicated, and I think these patients are often very sick, so it's reasonable to test both. If you think you know what it is for sure, like it's NMDA, you may only need the CSF, or if they've got facial-brachial dystonic seizures and you're sure it's LGI1, you may only need the serum. So it depends on your certainty, but a lot of times we don't know, and then testing both is best if you can. Costs and other things come into it though. Yeah.
And for paraneoplastic antibodies, you test CSF?
Same. Yeah, same. Yeah.
And also serum or just CSF?
We often test both, but we find we tend to detect them in both, you know, so with ANA1 or CRIMP5 or anti-Hu, those kind of things, we tend to detect them in both. But if you're highly suspicious, it's reasonable to do both, yeah.
We have other questions coming
Yep.
in. About ILON-G5 patients, unlike other autoimmune encephalopathies, can have a longer and chronic presentation. Is that usual?
Yeah, with the GFAP?
Yeah, ILON-G5.
Oh, IGLON5. Yeah, IGLON5 is a little slower. Yep, that's it's a little bit different. It's kind of an overlap syndrome. These patients have some tau deposition on their brain, and they present a little bit like PSP with sleep difficulties, a lot of sleep apnea, REM sleep behavior disorder, and then they will have, in addition to that, they will have a bulbar presentation where they may have swallowing difficulties and other things. Yeah.
Marianela Hernandez asks about GFAP. How long do you wait for steroids to have an action in a patient with a GFAP?
Well, it tends to be pretty quick. They tend to respond, you know, with the end of the 5 days, you'll see some response. And then we usually follow it with oral steroids followed by a slow taper. So over the course of 6 to 8 weeks, they'll usually improve. Yeah. And the MRI usually improves and the CSF improves. Yeah.
I had a patient with Mog with this presentation here, good response to IV steroids. I'm currently maintaining oral corticosteroids with 10 milligrams per day, waiting to complete 6 months to repeat the antibodies and decide whether to withdraw them. And I hope to be able to leave her without both first option. The follow-up. You have some experience in this spectrum about relapses, some recommendation you can give her?
Yeah, we tend to, as I said, we tend to follow the Mog cases clinically. So we see how they respond to treatment, and then we follow them clinically. So we sometimes will repeat the antibody titer, but we don't have a good sense yet, because some patients, it does tend to predict the patients who are more likely to relapse, but still a proportion of them will not. So I think it's better to follow clinically and then decide rather than on the antibody level. Yeah.
And Juan Cortez asks about, is there really a Hashimoto encephalopathy?
Yeah, that's the question. You know, maybe a lot of those cases were NMDA or AMPA in the past, or, you know, this is an old terminology. So I think a lot of those were related to antibodies that were not discovered yet at that time. So that's why it's important to test the antibodies. Yeah.
Good. There are no more questions in the chat.
Okay, great.
Okay.
So, like yesterday with Professor Aksamit, today we had a great lecture with Professor Flanagan. Thank you very much, Dr. Flanagan, for your presentation. Thank you very much, Lorna. I invite you for the next webinars that we will have in the next weeks. And don't forget to complete the encuesta de satisfacción. No olviden de llenar la encuesta de satisfacción, porque nos permite a nosotros mejorar nuestra presentación y saber en qué puntos tenemos que hacer correcciones. So thank you very much and have a good day. Ciao.
Thanks, Jorge. Thanks, Lorna. Thanks, everybody.
Ciao.